So currently I'm a gynecologic oncologist, and what I do basically is treat women who have either cancer known or suspicions for cancer. So what brought me into this field was initially my liking for medicine started back when I was in college. I was actually an EMT in college and really enjoyed that part. And one thing that really drew me to OBGYN initially was the fact that I was able to do surgery plus continuity of care, keep following patients as opposed to operating on them, then never seeing them again. With ovarian cancer, unfortunately, one of the things that we see when patients are diagnosed is the cancer is oftentimes spread throughout the abdomen and pelvis. So most times when we operate, the goal becomes not necessarily a diagnosis, but more a therapeutic goal of trying to remove all the visible cancer. So in addition to potentially removing the ovaries, the fallopian tubes, we may be removing the uterus and cervix, and then other tissues that are around the abdomen and pelvis, sometimes even organs such as the spleen or tissue around the bowels, and sometimes even resecting areas of bowel themselves. So it can involve a fair bit of extensive surgery, sometimes surgeries lasting 3 or 4 hours at a time, if they are reasonable candidates to proceed through that route. Stage 3 is probably the most common in about 75 to 80% of patients. And so it's rare that we find a stage 1 cancer. Sometimes the stage 1 cancers are found incidentally, maybe during a hysterectomy. And in those cases, we go back in to stage them. And stage really is more of a prognostic indicator than it is something that dictates treatment. With ovarian cancer, the majority of patients are still going to get chemotherapy, even if it's stage 1 or stage 4, but their prognosis really varies based on whether stage 1 or stage 4. Obviously, stage 1, a better prognosis than stage 4.